Carol is a 72-year-old female who was diagnosed with Parkinson's disease back in 2020 after developing a right-handed tremor. She currently presents with a chief complaint of gait instability and neck and back pain. She reports that her walking ability varies throughout the day and she may need her husband's support at times. Due to her feeling uncoordinated and having that decreased confidence in her balance. However, she states that she's having the most difficulty with her urinary incontinence and actually has scheduled surgery for that in August. She presents with gait instability, balance impairments, lower extremity weakness, orthostatic hypotension, and dizziness. Her gait shows decreased right arm swing, foot flat initial contact, and reduced push off. Her goals right now are to improve her walking abilities, balance, and independence so that she's able to attend her grandchildren's events. The first medication, carbidopa-levodopa, increases dopamine availability to improve bradykinesia, rigidity, and gait. It really helps improve step length, arm swing, and overall motor performance. So just making sure to schedule those higher level gait and balance task training during the on period of the medication, and really incorporate cueing strategies to support movement during the off timing. For our second medication, midodrine, it raises blood pressure by vasoconstriction to help reduce orthostatic hypotension, so it helps reduce dizziness during positional changes and improving safety with transfers and gait. So really making sure to monitor vitals, use slower transitional movements, and really include orthostatic strategies in her plan of care. The mini-BASS test was selected because it's sensitive to balance impairments in Parkinson's disease. It identified deficits in anticipatory and reactive postural control. It led to including reactive stepping, perturbation training, and amplitude balance tasks. The 6-minute walk test was selected to measure endurance and community ambulation capacity. It revealed reduced endurance compared to the age norm. It guided the addition of walking, treadmill training, and progressive aerobic conditioning. Our third test, timed up and go, with included cognitive. It was selected because it assesses functional mobility and dual task ability. It revealed mild dual task interference, and it supported the inclusion of dual task gait training. The first principle, salience, mattered. I applied this by integrating activities directly tied to Carol's personal goals, such as improving walking so she's able to attend her grandchildren's events. Principle 2, specificity. I applied this through interventions that directly targeted her deficit, so reactive stepping for balance, cueing for gait, and so on. Principle 3, repetition matters. Her home program included gait drills, balance task, and amplitude exercises to reinforce motor learning outside the clinic through repetition. The first personal contextual factor is her family support. Her husband and daughter assist with transportation and safety, which improves her adherence and allows for more challenging home-based tasks. Factor 2, active lifestyle and motivation. Carol regularly walks and uses her stationary bike when the weather is bad. This really supports a more intensive plan of care and predicts better outcomes. The hardest decision was determining how much intensity was appropriate to challenge her balance given her orthostatic hypotension and recent fall. I needed to balance safety with providing enough intensity to really drive that neuroplastic change. I'm least confident about predicting how her urinary incontinence surgery will affect her mobility and fatigue level. It is coming up in August, so I'm not sure how that is going to affect her day-to-day and if it's going to backtrack any of the physical therapy progress made.